Hello, and welcome to episode 5 of the Past Your Prime podcast. My name's Alex. I'm a professional volleyball player. This is Craig. Say something, Craig.
Hey everybody, I'm a physical therapist here with Alex. I feel like I always
You got something good.
bubble that up. Yeah, I actually told Alex that I was going to do this better today, and I clearly
You
failed.
failed.
I don't
All
know.
right, so you're a physical therapist.
That's all I got to.
You like
Run.
problem pathology.
I like I like patient problem pathologies. I like alliteration, and I like reading. So
I like long walks on the beach. All right, now that our dating profiles are done.
we are ready for it.
Okay, so we'll do injury updates with Alex and Craig.
Yes. We're gonna be. It's gonna sound cool. This is gonna be an update of injury status. My neck is feeling 100% better. My ankle is 100% better, and now I have right knee pain that is achy and feels terrible. Came on from absolutely nothing, but I can tell. No reason for it.
You recently had a birthday, so that's probably it.
I just hit
You just got older.
I hit 39, and my knee decided that it hates me and wants to hurt now.
All right. My wrist is still progressing. I've got PT again tomorrow. I've been pushing it every day. I'd say my hip is maybe half better now, so probably in the 50% range. Still dealing with a little bit of pain. We talked about it a little bit just before the start of this podcast, but it's kind of starting to improve. I really worked on not provoking it this week, so kind of cut off all jumping, kind of did like a little deload week in terms of lifting just to try and just stop the pain and hopefully get back to spiking in about a week from now. So,
I mean, it is interesting. So last week when we were lifting, he started crying, and we decided to
I did. I
broke down. Yeah, wept uncontrollably. And so due to his crying, we decided to make this the topic of the episode.
Yeah.
Right.
So I haven't cried at all this week.
No.
It's been great. Yeah.
No. The reason that we decided really to make it the topic, though, is when we were going through the lifting, there was a lot of the principles that we've been talking about in these shows really came out during the lifting session. The way that we were able to get through almost an entire workout kind of made you worse at the start by testing it, figured out his key sign, really figured out the scope of what he's dealing with, went through a whole bunch of exercises that one of them was a little surprising that it didn't bother you. Did some different tools, but we're able to do basically most of the week with no symptoms until yesterday, where you had a random increase in pain.
Yeah. So just so we can say the topic for today is, what does rehab and performance training look like with a hip injury? So we'll just kind of get started. But yeah, so yesterday went to the gym, did some single leg deadlifts, goblet squats to a box. Those were really my only leg lifts, and did my comprehensive warm up. And yeah, this morning it just is not as happy as it was when I went to the gym yesterday. So, so I guess, what are some of the common causes that aging athletes have hip problems or hip injuries?
It's a great question. So when we look at the hip, let's just hit the most common ones. So you have lateral hip pain, which can be a bursitis, greater trochanteric bursitis. It can be a tendinopathy. You can also have pain often in the front of your hip. That can be hip flexor tendons. That can be a arthritic hip joint. You can also have nerve injuries in the front, right, where your femoral nerve runs through. So you have a whole bunch of different tissues that can cause pain in the front. In the back, over the buttock, as we were talking about last time, that can often be a referral from the low back. So people will think they have a hip injury, but it's actually coming from their back. There's a really good article that talks about it, though, because for a long time, people would think, oh, okay, you've buttock pain's either hamstring or it's going to be back referral. And they did a diagnostic injection where they irritated the hip joint with a chemical irritant when they did the injection. And it's actually a very common referral, or really common pain presentations also in the buttock, even from the hip joint. So you can have a whole bunch of different structures that cause a whole bunch of different hip pain. And what I think happens with the aging athlete, aging person, is that you have an interaction with your daily activities, And then when you try to do your normal exercise, you have some loss of health in the tendon, joint structures, and you push through it, hurt yourself over and over again. And so less and less things are needed to make you feel worse and worse and worse.
That's what I was doing at kind of the onset of my TFL injury, is just kind of pushing through it and using good old Tiger Balm.
Tiger Balm.
Yeah. So I have not used any this week. And once again, just trying really hard not to provoke it. But
can you tell me the truth though? Have you used Tiger Balm on it?
No.
Not this week?
Not this week, no.
Okay.
Yeah. Right. I didn't really need to either. Like it just progressively was getting better every day until today.
Okay.
So feeling good about that. But so what does assessment look like? If you're, a patient comes to you with hip pain, what does, I guess, a movement screen or what does screening look like for hip injuries for you?
So when somebody goes through a hip injury and they come into, say, physical therapy, you go into your doctor's office and they're really trying to diagnose what the actual structure is, a basic hip exam will try to differentiate all those injuries that I just said. So for example, if it's the joint that's hurting, there's going to be very specific motions that will feel limited and painful. So we can do passive range of motion. Your hip is interesting in that it has so much mobility.
It seemed like there was a lot that you went into there, that there's just a litany of problems that could come up there.
So if it's the joint, you'll typically see a loss of hip internal rotation. You may see a loss of motion everywhere relative, and you can compare it to the other side. So if you feel hip stiffness and actual motion loss, that could indicate that there's a bit of a joint injury that's happening.
Or like inflammation.
Yeah. You can also have a labral tear or labral impingement, labral irritation. That one's going to be mostly painful. There's a test we call fader, which is you flex the hip forward, you adduct it, and then internally rotate it, and it pinches the labrum. So that can be a very specific test
And I've had that before.
No, you had it. So I will sometimes say hip impingement, and when I say hip impingement, I will use it in a way that will not be consistent with what you'll read in the literature. The literature will have hip impingement, and it'll say femoral acetabular impingement, or FAI. There's two variations of it. There's a cam impingement where the neck of the femur thickens. That's more common in men, and that deformity will cause labral issues.
Okay.
In our female population, it's more common to have what's called a pincer impingement, which is, so you have the femoral head, and then you have the socket that it goes into. That's called your acetabulum. So the rim of the acetabulum will become sharp, called a pincer impingement.
Okay.
And women, they also tend to have smaller femoral heads, so they're going to be able to pinch with that impingement called a pincer impingement, and that'll also tear up the labrum as well.
Yeah.
So kind of horrible, but that's what you can suss out just from range of motion testing. Then you want to also look at resistive testing. That's what we call it with your being TFL. So you can do a very specific test to look at the specific musculature. So you have a whole bunch of hip flexors. So you have your TFL, your sartorius, your psoas, adductor longus, adductor brevis, pectineus. Those all flex the hip. Then you have the ones that abduct the hip. So your TFL, glute minimus, glute medius. So you can test these in different ways and suss out which muscle tendon gets hurt when you do the resistive testing.
And we talked about it a little bit just before the podcast. So I didn't have a way to self-test. And so that's something that we probably need to develop, because I needed some sort of resistance to kind of be able to test my TFL. Jumping was a test that obviously triggered it. And so I didn't want to do that, because that was kind of the worst of the worst triggers. But
yes, it's a great point. So I think it is hard to sometimes break apart the difference between a trigger and a key sign, right? So a key sign is something that you can use to see, is your body having a good response to the activity or the treatment?
It's still kind of like minimally bothering you.
Yes.
Yeah. As opposed to a full on
this is so bad.
Blowout.
So blowout. Yeah. That sounds terrible. So you should not pick a key sign that causes any level of blowout. It should not cause pain. It should not be severe pain that then makes every other thing hurt you, right? So I kind of look at it on a spectrum. So you you have triggers, and triggers can be one of two things. It can be hidden or it can be obvious. An obvious trigger for you when we started this was jumping. So every time he would jump, he would get severe pain and cry like a child. And so tears, crying, those are bad things, right?
Yeah.
But really though, were you able to work out after you blew it up?
I wanted to avoid it, but no, I just went back and was like, I'll just perform through this.
Yeah. That's typical,
Yeah.
right? So so if you, so some that is that's a huge issue, right? Where you can have severe pain, but you've trained your brain to push through it. That is a horrible key sign, and that is an obvious trigger. A hidden trigger, which, to go back to your original or maybe your second question on why it's so common in the aging person, is that as we go through life, we learn and develop mannerisms and things that we just do without really thinking. And I think those hide when you're hurting yourself. So for example, sitting, right?
Caution goes to the wayside. We're just gonna push through this.
I know, I call it the trained brain.
Okay.
Trained brain. You know how you can focus? You focus on something. So unless you have adult ADHD, you could train yourself to focus and not even realize it's hurting. Or like when you're playing a game, how often have you been in the game and it's almost like the activity causes you to ignore it, and then after you get done, you feel horrible.
Right.
Afterwards.
I feel like just as an aging athlete myself, that I've felt the pain more often in recent years, as where like, yeah, when I was in my 20s, it didn't matter. I played through a torn labrum in my shoulder and didn't realize it until 2 days later.
Yeah, that it was actually hurting you.
Yeah.
Yeah. And then, so your system changes obviously with aging, but I do think that there's things that you're able to mask in a way, and you won't even realize that those are bothering you. That's a hidden trigger. I believe there's way more hidden triggers in our aging population than there is in younger, right? So if you have to get something done at work, you're gonna hammer through and say you have to sit down to do it, and that's causing slight compression on your TFL the whole time you're sitting. And then you go play, and if you were just doing the sitting by itself, it wouldn't be an issue. But if you were just doing the game by itself or the exercise by itself, it wouldn't be an issue. But you do those together, that's an interaction, and now you have a symptom. Right. I think hidden triggers are the biggest issue that I deal with on a daily basis for people with recurring injuries. So where something just seems like it starts to go farther than the normal healing time. You've made all these adjustments, but it seems like it's just this nagging, common, recurring problem. To me, 9 times out of 10, you have a hidden trigger with some level of an interaction that isn't actually painful enough for you to stop it, right? Like it's obvious to stop jumping.
Right.
It'll be less obvious to stop something that doesn't hurt in the moment, that's then followed by an activity that seems mild and blows you up.
Right. So how do you differentiate between something that is, a major injury and, for me, we were doing some, goblet squats and there was a tiny bit of pain. What's the difference between that and then, my, 8 out of 10 pain level on a full jump?
So for me, it comes right back to the key sign and then the person's ability to feel better from some level of therapeutic activity. So when we looked at your key sign, jumping could have been a key sign. Say jumping caused really mild symptoms. We could do a treatment and it was gone. And then we could do it after you got done working out and it was still gone. Well, that would still be a good key sign. But right now it's so painful. There's nothing we can do to make it feel good. Right. So you can do a key sign. You can pull it back to where you find something that feels a little uncomfortable, but it's not severe pain. You apply a treatment. Like for him, it was resistive testing to the TFL. We could do some level of treatment to it and then it would go away.
Right.
And then throughout the workout, it would feel good. And then say we testing at the end, it's still good. Then we know you had a good workout. That would be a great key sign, especially at the beginning. If you look at severity though of injury, if you can't do normal activity, if you can't walk, that's an obvious one that it's you need to be paying attention to it. But if it's something that takes significant effort to provoke, then it's very different.
Right.
And I can give you an example, a recent example. I had a high level ultra runner. So ultra runners are insane by nature. They're
That's unfathomable to me. It's like there's no way I could barely run a half a mile.
So you're still on your normal increase, right? So you're up to 0.7.
I should be close to 0.7. Maybe I'll try that today. If I'm okay to run with my TFL, I'll try to run 0.7 miles today.
So compared to the 0.7 miles, this
They run like 7.
oh my, yeah,
right?
oh my Lord, yeah, yeah. So 100 miles, and they can do insane distances. Yeah, but this person's injury would not really come on until mile 19, mile 20, where then they'd get really severe pain. I don't want to go into too many details since it's an actual person. But what's interesting about it is in that situation, they're able to handle an enormous amount of load for a really long period of time. And so the solution is really simple. You make it so that accumulative overloading of whatever structure that's getting hurt, you make it so it doesn't get overloaded, and then you can rehab them very easily. So it's, even though the person's feeling severe pain, the injury itself is not severe because of how much activity they're actually able to do. I feel the same way. If you only feel the injury with high level activity, descending on a hike after you've hiked for 10 miles or jumping, right? Those are high level activities. Well, it may be difficult to get that to be pain free, but it's not a severe injury, but it still can be very difficult to get the in game rehab done.
Okay.
Yeah.
So like what are the common mistakes that athletes make when doing some hip injury rehab?
The most common mistake?
Yeah.
I would say the most common mistake is really not monitoring their response to whatever the activity they're doing. So when we get into the mindset of exercise, the idea often is to hammer as hard as you can, to work out really hard, because we all have limited time, right? We have these responsibilities in our lives. And because we have these responsibilities, we view that hour or 45 minutes or 30 minutes that we may get to work out, we want to make sure that those are valuable. And we have a belief that the biggest value is going to be the hardest workouts you can handle. And there is going to be a very big difference between, for example, what your TFL right now can handle and what is actually going to be hard for you physically, like what's your actual exercise.
Because I've been hitting it so hard. And I think that's something that I regret as, growing up as an athlete, is not having as much intention in my workouts. Like I have so many other responsibilities outside of the gym and outside of training where I want to be able to spend time with my kids and my wife and, do fun things. So like that hour to hour and a half in the gym that I have is like, I want to squeeze as much in with as much intensity, as much load as I can to have the best results in a short amount of time.
And I would say that is that's normal. And I think your value of your time and how it's constrained now with other responsibilities is such a common problem that we have to manage. And so that's why I'm saying, if you have a tissue capacity issue on a specific area, we can work around it and you can still work out really, really hard. But if your tissue capacity is here and you want to exercise up here, that gap is your injury.
And you had to like talk me into a deload, basically.
Yes.
Just stop squatting, put the bar down. We can do some other things to load the quads.
Which was interesting, right? So after our last podcast, we went in and did a whole lifting session. And what was fascinating, and we're going to hit that today, we're going to go through it, but your biggest issue is literally this issue, is that you value your time away from training just as much as the training. But when you have that limited availability, the idea is I want to hammer, and I want to hammer as hard as I can because I know that I don't get this hour back.
Right.
Whereas in the past, if you're sitting there, you're in college and you could go lift for 3 hours and it would be a blip in your day. Whereas I don't remember the last time I had 3 hours to do anything besides work or some other responsibility. Yeah. So
you get your 8 hours a day at work, but you don't get your 8 hours a day at the gym.
It's not your that's not your time anymore. But the bad part about that is I think that is the most common driver of repeated injury. So I know I've hit this a few times. I'm going to do it again, but so you have a problem sometimes where you don't know the diagnosis. And that can take a lot of work to really figure it out. It depends on the different body areas. but this area is one that can commonly be difficult to diagnose. So you can have what appears to be a tendon injury actually be a labral tear, and it can seem like it's responding well, but then it like resets. So there can be that. But I would say the next one is get the symptoms to stabilize. That's the next problem. I can't make myself feel better without dipping my entire body into Tiger Balm, right?
That sounds great.
I mean, it does sound. Dude, if we don't get sponsored by Tiger Balm, we got to get sponsored.
Or we need to develop our own
drug.
Tiger Balm.
Tiger Balm. It does.
Sounds close enough.
Yeah. Called a KB. That's awesome. Okay. But so that would be the other one. But I would say the most common one is activity progression, which is where you're trying to improve your tissue's ability to handle increasing load, increasing activity.
Like resetting progressive overload.
Yes. And setting it at the correct level where your tissue handles it. Our team calls it the Rehab standard. But and the idea is often you get stuck in a performance standard, meaning you're trying to improve your performance. So you're working at a really high level for your whole body, but that tissue doesn't handle it. And that's where you get stuck in this recurring injury hell, because you're trying to put it at a load that your brain has trained at for a long time, developed almost like you enjoy it, right? But then it keeps on setting it back every single time you try to progress.
Yeah.
And so that's exactly what you were doing. And what was interesting about it was you could still handle a lot of load, but you could not do it with squat. So squat was just not going to be the exercise that we used. Right.
And we switched to a reverse lunge,
which is crazy.
Yeah.
That reverse lunge caused no symptoms. Would not have predicted that it was that well tolerated, but that's also why we do some of those tests, which we can drop into that too. But I would say that is the number one issue is you think you have to hit it as hard as you can on that tissue as well. And there's a whole bunch of outside psychology around it. And it's not just a rehab.
I've got kind of two semi-related things. So one is training aids. I think training aids can help a lot, and because we used some in last week's workout to try and, reduce symptoms, but then also warm up. We were just talking about time in a gym, and being at a commercial gym, I see so many folks that just come in and, just go straight to a tricep press, at max load. And I don't know that you necessarily need a warm up for that, or maybe you're just starting with lighter weight, but I've pretty much done the same warm up standard for the last 10 years, which included, banded side steps, which we just kind of changed up. And I think we might be able to share a video of what those look like.
If we can figure the time out.
Yeah. But prioritizing the warm up, I think, is important. I mean, I was doing plyometrics every single workout just because I did not want to lose my ability to jump, which now I've lost my ability to jump. So that kind of stinks. But a part of that was making sure that I had my full kind of thorough warm up prior to getting into my jumping.
Why do you think you lost the ability to jump?
Because it hurts.
But so in your brain, but does that mean you've lost your ability to jump because of pain? But are you saying you're
not? Yeah, I just don't want to jump to provoke.
Got it. Okay.
Yeah.
Okay.
I guess that's what I was getting
at.
But so how important is a warm up to, progressing your training load?
Critical. So you said two things. You said the training aids and warm up.
Right.
So let's hit. Which one do you want to hit first? Warm up. So warm up. I think the warm up gets a bad reputation because people see no value in the warm up. They actually use the exercise that they're going to do as a warm up. The most common mistake with that one, the most obvious one, is running or any dynamic activity like that, because it seems easy, but it's actually not easy on your body. So a warm up, if you think of it, is you're doing stuff to get your body ready to tolerate primes. Ooh, to move your prime. You get past your prime.
There you go. That's what we're going for.
So you're looking to get your body primed for the movement that you're going to do. And what's funny is you'll get a better workout if you warm up than versus if you don't. So when I see it, the most obvious ones are activities that people use that activity as a warm up. That makes no sense. For example, when you're going to lift, you want to get your whole body tissue, all your tissues warm. It's why you say the term warm up. You also want to address any lingering issue. You want to test your key signs and you want to make sure that those key signs you're able to work those till they're negative, right? So it's your warm up may be 15 to 20 minutes, but by the end of it, you should be breathing hard, sweating, actually feeling like you may be getting a workout, but it's a progressive increase in activity. And then you're checking the key signs to make sure that your body's actually having a good response to it. And so you're making it so for example, if you went in cold and you went and did squat, it's going to feel dramatically worse than if you did a well primed, well focused warm up. So for example, you would do, say you want to hit squats. Well, you could do sit to stands where you actually sit down, you take out the isometric phase and then stand back up. So it's less effortful for the body, right? Then you could hit things to target the glutes and relative to the hip flexors, because right now you're showing that your hip flexors are overactive relative to the glute. And that's part of why it hurts, right? You can make sure that the tendons are actually warm and healthy. So you could do some level of tissue work to the tendon, follow that up with an activation, and then do the squat patterning again. And you can work through those over and over and over again until resistive testing of the hip flexor is now pain-free.
And it's like warming up your muscles, not like, getting on the bike until you're sweating. I think that there's a common misconception that like, okay, I'll do 5 minutes on the bike and now I'm warm. Like, okay, maybe if your activity is riding the bike, then you're warm for riding the bike. But once again, if you're going to squat and you've got a hip injury, then just riding the bike is not going to warm you up effectively for
I totally agree.
the activity.
I totally agree. And it's not that the bike would be a bad idea. If, say
it could be a part of it.
It could be a piece of it,
Yeah.
but it shouldn't be the only piece. So for my knee stuff right now, my warm up would consist of spinning on the bike 2 to 3 minutes, maybe, knee traction. After I test it, I have a little bit of pain with end range extension. I traction it till that's gone, followed it up with terminal knee extensions where I fire the quad moving into extension, sit to stands, some weight supported lunges. And then I may repeat that over and over again until my extension is pain free. And then I can do whatever my first exercise is. Let's say it's barbell back squat. Now it feels fantastic and not symptomatic.
What should it look like for my hip?
For your hip?
Let's compare.
Yeah. So his hip.
Not what I normally do.
So you have your general warm up where you're basically in the whole body ready for all the activity that you want to do. But for yours, you would want to do probably ball on the wall, unless that's too intense, or
which it was at the beginning of the week. And we talked about that a little bit before the podcast, that like I have a trigger point on tip that was just blown up. That's what would put me in tears.
Yeah.
Last week. But
that's actually a good point though. So like that, so
I didn't cry.
Yeah. He cried like a child. And what's funny, it made me realize that your deep voice is not actually that deep. Oh, it hurts. All right. So here's a great example. So we started with the ball on the wall, but the ball on the wall is too intense. The focal point of the ball would makes his trigger point worse. So you would want to do, that may not be the order you go in, or you could do something like a massage stick that has a bigger surface area to work the tissue. But if it doesn't make it feel better, then it shouldn't be part of your warm up. Right. So there's sometimes where
foam rolling, for comparison, did actually make it feel a little bit better.
Boom. So you could do that but let's say even foam rolling hurt, then you just take out the soft tissue warm up piece, or you change the order of it. So instead, what I would start with would be some level of a bridge where we take the hip flexor out. So
I've been doing bridges.
One of his issues is he's getting a co-contraction as well. Like the TFL is firing in activities it shouldn't fire. So getting hip posterior hip activation. So the glute max, working the things that extend the hip relative to the hip flexors was helpful. And that's where if we did something that did both the TFL and the glute med, hip abductors, I may be talking too much, but if you get both of them at the same time, he may not be able to differentiate it unless you know where it's supposed to be felt.
Would that be the banded side step?
That'd be the side step, which we'll show. We're going to try to present in a second to show. Well, might as well show it. All right, so here Alex is doing a side step. This variant's a little bit different because he's keeping his legs relatively straight and not going into a flex position, which will get a little bit more quad than I want. So when we're doing this side position, we find that you can get the glute medius a little bit better relative to TFL. We want to make sure that the TFL is not turning on, so he should not feel this in the front of his hip when he's doing it, but more kind of back pocket, slightly posterior to the greater trochanter. So the side step piece was interesting because the way that you, like where you just said, we modified that so that you're not getting it as much in the hip, in the front of his hip. And so you can make a modification to a normal one, but you really want to make sure with your warm up that you're getting the result that you want. So for example, I would have we'll retest that after he gets done with doing the side steps and see if the resistive testing to his hip flexor is less painful. And if it's not, say if it's worse, that's a horrible exercise and it goes away. Right. So it doesn't matter if the idea is supposed to be therapeutic. It doesn't matter if the soft tissue.
It has to actually be effective.
It has to actually be effective. Right. And that's where it drives me nuts. But there we have this whole idea around research. So there could be tons of research that shows that's the best thing to do for the hip flexor. I don't care if in the moment it makes you worse. It doesn't matter. And it's one of the cool part about clinical work is you don't have to say, well, research says this should be helpful. Well, I don't give a crap. Like if you feel worse in the moment, then quit doing it.
This patient in front of me tells me it's not.
Yeah. So you should feel better at the end of the warm up. Everything should feel looser. So I kind of look for at the end of the warm up, you should have that feeling where your body feels ready to take on activity.
Yeah.
You know how often, when I can tell when I don't have a good warm up is when I start to do the exercise, I feel stiff. It feels horrible, right? It's like, oh my God, my quads feel like they're about to seize up. You know what I'm talking about?
Oh yeah.
And
it just, you don't have full range of motion.
Yeah. You feel stiff and uncomfortable, and you don't have to. That the warm up should basically knock that out. And if you don't feel that, imagine now I'm going to go play a game or something where I need to be able to move quickly and feel good while I'm moving, and you didn't do a warm up, and now you just feel like garbage for like the first 10 to 15 minutes that you're doing,
and you're spending that time actually getting warmed up.
Yeah, it makes no sense.
Perform at your highest level.
It makes no sense. So that's the first one. So warm up, it should be, especially if you're dealing with an injury, you should have at least a piece of it built around that injury, making sure that that muscle, at that joint, that tissue, whatever's hurting you, is going to have a really good response for the exercise load that you're about to put onto it.
Yeah.
So remember, if I said that your tissue capacity is here and you do a crappy warm up, your tissue capacity may be down here now, which may not be in the video. So it's below the video. But if you do a good warm up, you may increase this capacity by 50%. Like a dramatic
that's a ton.
amount. It's a ton. It's a ton.
And that's going to reduce your pain and have you performing at a higher level.
Much higher level.
Right. So let's talk about training.
Training aids. So when I think of, I say so a lot.
That's all right.
Yeah. So when I think of a training aid, it's within this broader scope that our team talks about, which is artificial stabilization, which is using tools to allow your body to handle more and more load or more of the activity that typically would hurt it. So say your tissue capacity again is here with the training aid. It's like you get another stack on top of it of what it can handle without getting hurt. So for a TFL injury, there's a few of them. You can use what's called an SI lock belt. That's typically used for pregnant women or women with, it's more common in women to have these pelvic instability.
That's what I used last week.
That's what you used last week, and it felt good.
A little bit. Yeah, I don't think it made a major difference, but a little bit is a little bit.
But yeah, made a little bit of difference, right? And we'll use that around hip flexor tendon injuries because it'll compress the tendon and typically have a nice, pleasant response. The other one that we use is an adductor wrap right around the kind of the groin area that you'll see when people say they have like a groin pool or like an adductor tendinopathy. Those also work really well. And what it does is it compresses the muscle, and that can often improve the tolerance of the muscle to handle load.
Okay.
But then other ones you can kind of think of would be using a heel lift underneath your feet when you're doing a squat. Sitting down to a box would be like an artificial stay, but like where you're not having to do the isometric phase at the bottom of the exercise. Right?
Do you want to do it? Do you want to show those?
Yeah. So I want to show these two. So let's see if we can do that.
So what we're showing here is just a normal squat, and this is kind of a squat progression. And then just kind of some hit exercises that use training aids. So then we move on to a heel elevated squat. From what Craig told me, I've got great form here.
Just look at that form.
And what does the heel elevation do?
Well, it's actually a good question. I think it shifts your body weight forward a little bit.
Okay.
And allows you to get more into your hip without it being irritated, but it changes the pattern. At the end of the day, the big thing is it lengthens the lever of your lower leg and it just dramatically improves the pattern. So if you're somebody who struggles to get that last little bit of squat, the heel lift just is such
more range of motion.
It gives you way more motion and feels better. Now, what you just did, you had a target right there. So you did like a butt to the box or a full sit down. Now you're doing activation, which this will get a little bit of the hip abductors. And so sometimes this works really well with TFL injury, but sometimes it actually can make it worse.
It made it easier for me to do the exercise.
Beautiful, which is what we want to see. And now this would be an example of a lateralization. This is one that surprised me last week when we did it, but he went from not being able to, he can't squat without some level of symptoms. But then we do this lateralization and he has no symptoms, and we're still getting, you're going to get quad, you're still going to get good glute activation. So you're hitting all these. Now, this would be an example of a complete shift away from the exercise. So we call it an exercise alternative. And you don't want a workout to hurt you, right? So say we did all of those and it still bothered him. Well, we'll pivot all the way away from an exercise that hurts you to a pull. So this would be an example of lower extremity pull versus the one before with squat is the lower extremity press. And that's just perfect form. Now, somebody like him where he's so tall, using that lift makes a big difference. So hopefully
that all worked.
Hopefully that technology worked, and that's actually pretty cool.
Yeah.
So, but just one more thing on that though. So when you got done with your workout last week, it was after I irritated it, tested it. We figured out that you have a large negative response to palpation. And then we also have learned that he doesn't do well with the soft tissue massage. I would say the vast majority of people that I see with a TFL injury, the massage helps a ton. So does the inhibition exercises. And neither of those had that response on him.
So case in point, you said earlier.
And that's one of them where you have to test it out. So even though we're giving some of these specific things, what I want to hammer a few times is you can have the exact same injury that Alex is currently dealing with and need a very different plan. And so that's where the principle, like as we work through this, kind of the scope of what your problem is, make sure you understand what that is. And then be very honest, is the things that you were talking about making it feel better? If not, it's okay to adjust it. It's go to make a few changes, which is what you did this whole week.
Yeah. And once again, it generally got it better until today. So I'm trying to spike volleyballs in next week. So is there an overarching sign that would say yes, you should actually go and try jumping again?
Well, at the end of the day, I don't want you afraid of your body.
I don't want to be afraid either.
I just want to be afraid. That's terrible. So I also don't want to make things sound more serious than they are. When we just looked at your thing, you're able to make the resistive testing pain-free on your own. We were able to load the squat, and even though it hurts you, it doesn't stop you. And even though it hurts with the jumping, can you jump through it?
I haven't tried in a week, so
we'll try that after this.
Yeah,
and I will video it if he cries like a child, so you guys can see
the proof.
But I'm never afraid if it's not a red flag, if it's not a sign of something serious. I'm never afraid of somebody pushing through pain. So I'm not saying that all things have to be completely pain-free. And I think you can decide when you want to hit it. But I think for your mental health, you got to go. You got to do it.
Yeah.
And I totally would, because I think you got to get out there.
I really wanted to try yesterday, but I promised myself that I'd wait one more week and one more PT session for my wrist. So
I'm excited.
Yeah.
Yeah. So in those situations though, it's, I never want to say no unless I actually think that you're going to make it worse. And even if you make it worse, I don't think you're going to.
We can make a plan to make it better.
You got it. Which is, I think, always a focus at the end of the day. We don't want, when you're past your prime, there's going to be times where you're going to be a little uncomfortable when you're exercising. But you don't want to make these basic, simple mistakes in the warm up, using training aids. They're just so useful. They're so useful. And if you use them intelligently, your workouts become therapeutic, which at the end of the day is what we're searching for, right?
Yeah. Therapeutic for the body and for the mind.
Yeah. Therapeutic for all of it. And your tissue capacity goes up. And the holy grail of any injury when you get through activity progression is that tissue that's always been bothering you, where it keeps coming back and keeps on hurting you, that you get it to match your exercise capacity. And once that happens, well, then you're just strong. Yeah. You hammer, you can perform at a higher level, but that's really where you want to get it. And when I see an incomplete rehab, I always look for the history of them saying it's recurrent, where it keeps on coming back, comes back in the same way. I got 6 months in and now I'm all the way back to where I was. I have these uncontrolled or flare-ups. You have flare-ups that seem to last for months and months. If you can't manage an injury within 2 to 3 weeks, you're not managing it. You don't have a good plan around it. And that would be a time that I would look for support, right? So for example, with my ankle, when I rolled it, the most obvious thing that you would have thought would have been a ligament injury. But that's when I had my wife examine it, it was a joint injury, and traction it made it go away immediately. And oftentimes with treatments, that's the normal for us. You may have some like yours where there's an underlying co-contraction, some other stuff that's developing, hidden triggers, but we still have a plan and we can make it better in the moment. And we put a plan in place where now we can be more effective. But if you have an injury that then lasts for like 3 to 4 weeks, 5 weeks, and it's not changing at all, your plan sucks and it's not working.
Yeah. And listen to your body. I mean,
yes.
If next week I'm not able to jump, I'm probably not going to jump because I'd rather get to a place where I can rather than risk it. So we'll see how it goes.
Yeah.
But
well, and I think we can, and it'd be kind of fun to work through jump mechanics maybe next time.
Yeah. I do so much research on this, not like research, but I listen to a lot of other folks talk about it, and it's interesting. I feel like I've learned a lot through not being able to play I'm not an expert, but exercise science and, like you said, jump mechanics are a cool thing when just looking at the way to maximize your jump performance.
Yeah. So we got to get an update on that for next week.
Yeah.
So I think we hit up.
I think that's a good place to close.
Well, I know we had comments though.
Oh, we did have a couple of comments.
So what was the first one?
We had a question about lumbar traction
during the workout. How do you traction during the workout?
Yeah. Let's do a quick screen share.
Okay.
To show what it's called banded lumbar traction. This is something that I used to have to do every day for my low back, and it helped a ton just with unloading my back. And so this is a lovely video from Craig's clinic. But basically what you're seeing here is you've got a band with your knees elevated on the floor. You can use a wedge, not necessarily mandatory, but it definitely helps. And I got to a place where I could pull pretty heavily on that, whether it was in the morning or during a workout. But it just really decompresses the spine. Yeah.
Yeah. And like the other stuff though, if it doesn't make it feel better, if it feels worse, obviously don't continue, but it should feel, you could retest, like I said, the low back key sign. Easiest one to try to touch your toes, lean back side to side, say those hurt or feel stiff. You do the traction like you just described it and it goes away. Then it's a good tool to have in there, and you just add it in throughout the workout.
Yeah. And then
how long would you do it for when you were doing the workouts?
Probably like 30 seconds to a minute. It didn't take very long.
Yeah. So you don't have to go forever. We will sometimes when somebody's in early stages of rehab, we'll have them go longer.
Right. Like 5
minutes, but like you just said, 30.
Yeah. And if it's in the middle of a workout, if you're looking for kind of just that quick decompression, it was super helpful.
Yeah. And the effect on the key sign.
Right.
Yeah.
We had one more comment about yoga and I believe some single leg balance.
Yes. Was it that it hurt?
Right.
What was the question? You could click on that.
Yeah.
We're using technology, folks. It's amazing.
Having trouble with standing balance on one foot, could that be due to an old ankle injury? And then does engaging my abs make it easier to balance?
And why does engaging my abs? So she's already doing that. So obviously, yeah, if you're balancing on that foot and that's an old ankle injury, it makes total sense. Did we talk about a functional ankle instability before?
We did.
Yeah,
right? We're single leg balance, and that's why I understand it's been in all of my workouts.
Yes. Well, so there's really 3 systems that help you balance. You have your proprioceptive system. That's like the nerves in your body that give you feedback to your nervous system about where you're at. You have your visual system, right? So if you don't,
which is fascinating.
Yes.
Try standing on one leg with your eyes closed. You will realize that you do not have that great of balance.
Yes. You'll feel drunk. You'll feel really, really weird. And especially if you haven't done it. If you haven't, good God. So I know I'm having family members that have been watching. Please, guys, do that like in a corner so that when you close your eyes,
area,
you don't fall down. I've had before, where somebody will come in. This not even a joke. It's happened more than once where they'll describe they have this really horrible feeling that they're gonna like pass out, lose their balance, and what it ended up being was they were so visually dominant that any level of loss of vision caused them to almost fall down, even in a normal square stance position. It can be very debilitating. You could have a disturbance in the visual system as well, where you become visually dominant. And when you're in yoga, you're not looking at your foot, or you're not able to use your eyes to balance yourself. So that could also be a piece of it. And then you have your vestibular system, which, you think of vertigo. What'd you call it? The vestibula?
I don't know. You said it.
Vestibular.
I can't say that.
So that one's like kind of an inner ear issue. And that's actually another fun one where you can move your head around as you're doing your balance activities and see if that really disturbs it. Right. So most likely it's a combo of all of those. But if it's an old ankle injury, then by the way you defined it, you probably damaged your proprioceptors. And we call that a functional ankle instability. And so you probably lost some of the input from your nervous system to your brain on where your foot's at. Balancing, you may want to start with seeing if you can balance just on one foot. If that's too hard, regress it to maybe like a split stance position where you have one foot behind the other, or do a toe touch. So the back foot is actually still touching the ground while the other foot's still down, but back it up to where you can be really successful with it, at least 30 seconds, and then throw in some eyes closed, eyes open, like pulse it like 5 seconds on, 5 seconds off with your eyes open, eyes closed, and it'll get dramatically better. So functional ankle instability is so common. Like Alex had said before, it's such a useful thing to work on because you can retrain those nerves to do very, very good again. But once they become disturbed, they don't always come back. And that's something I wish I had known in my own career with football and basketball. I used to struggle with those all the time, and I'd wear these braces. But the issue was that the braces didn't give me back that sensory input. So I would still roll the ankle. And so this is just a great one that you can totally work on. Engaging the abs, I'm guessing it helps to limit probably some perturbation that's happening at your spine, which gives you more control. Do I actually think it's improving your input from your nervous system? It could be. I honestly just think you're just reducing the degrees of freedom in your body, so you're able to control the whole body a little bit easier.
Awesome.
Yeah.
Well, if you've got a comment, drop it down below and we will try to address it. Aside from that, like, comment, subscribe, share, follow, rate it high.
Rate it high.
Woo!
All right.
PYP.
PYP, baby.
Take care.
See you guys.